Hi, I'm Spencer Ceballos, and I'm a fourth-year medical student at the Cleveland Clinic Lerner College of Medicine. Thank you for joining me today for this presentation entitled Characterizing Emergency Department Utilization of Homeless Pediatric Patients in a Large Health System. My co-authors and I have no disclosures. The U.S. Department of Housing and Urban Development estimates that over 111,000 children are homeless on any given night in the United States. Homeless children have a higher burden of physical and mental health conditions and increased healthcare spending compared to housed children. This population also experiences delayed access to care and higher rates of emergency department visits and hospitalizations. However, this population remains poorly characterized, and not much is known about how homeless children utilize the emergency department for care. The objective of this study was to characterize the demographics and disease burden in homeless pediatric patients presenting to EDs in a large healthcare system. We used emergency department visit data from between 2014 and 2019 from Cleveland Clinic Health System EDs, which included 18 emergency departments. First, we identified patients as homeless through two methods. One, whether their address was listed as homeless and they had an ICD-10 code indicating as such, or two, looking at their home or billing address in the electronic medical record, whether that matched up with a list of addresses of homeless shelters or transitional housing in the region. Next, we looked at patients who were 18 years or younger at the time of their ED visit. Demographic and diagnosis information was collected and analyzed for all visits. Descriptive statistics were calculated. Encounters were grouped by disposition. Admissions, observations, and transfers were considered hospitalized, and discharges or those leaving prior to treatment completion were classified as discharged. Expired patients or those with unknown dispositions were excluded. Over the study period, 1,001 homeless pediatric patients presented for 3,478 ED visits. Compared to homeless adults, homeless children were more likely to be female, with 48% of patients in the pediatric cohort being female compared to 34.8% of homeless adults. Pediatric homeless patients were more likely to be Black or non-white, with this population consisting of 70.5% of our group, compared to 51.3% of homeless adults. 2,915 ED visits had a diagnosis code. There were 337 psychiatric visits, representing 11.6% of the total, 9 substance-related visits, representing 0.3% of the total, and 2,569 medical visits, or 88.1% of the total. 433 ED visits resulted in hospitalization, or 14.5% of ED visits. Of these, 46.3% of psychiatric ED visits resulted in hospitalization, 1/3 of substance-related ED visits resulted in hospitalization, and just 10% of medical-related ED visits resulted in hospitalization. Overall, 37% of pediatric hospitalizations involved a psychiatric diagnosis. Compared to adult ED visits, pediatric ED visits were less likely to result in hospitalization, with 14% of pediatric ED visits resulting in hospitalization compared to 24.5% in the adult population. They were also less likely to involve substance-related and psychiatric diagnoses, with 0.3 and 11.6% respectively, compared to 8.9 and 16.1 in the homeless adult population visiting the ED. Homeless pediatric patients presenting to the ED are distinct from the adult population demographically and in terms of their medical and psychiatric disease burden. Better understanding the medical, psychiatric, and social needs of this at-risk population may improve the delivery of tailored ED care and services. Thank you for joining me today.
Hi, everyone. My name is Tad Schmitt. I am one of the second-year residents at the University of Wisconsin-Madison, and I'm going to be discussing the adaptation and implementation of a clinical decision support tool for child abuse screening and evaluation in the emergency department setting. So one of our essential duties as EM providers is effectively addressing cases of suspected non-accidental trauma, maltreatment, or neglect. So a clinical decision support tool, which is often seen in many systems for things like sepsis, could help providers in screening for and then subsequently evaluating a different can't-miss diagnosis. Here, I show the outline of our clinical decision support tool. So this was initially designed in Cerner at the University of Pittsburgh. It contains first 4 separate triggers, each of which can fire individually, which are the chief complaint, a positive result on a nursing completed child abuse screen, the independent order of a skeletal survey outside of the order sets in the CDS, and then a final diagnosis made at admission or discharge. Each of these fires off a best practice alert, which is a pop-up that goes to faculty, APPs, and residents that provides recommended next steps for evaluations, orders based on individual presentations, and then common consults. So if in a clinical encounter, any of these triggers were to be met, the provider would see a screen that looks like this, which you can see recommends completely undressing, checking the frenulum, and reviewing the chart for anything that was been previously suspicious for possible NAT or maltreatment, and then has links to individual order sets that we designed to help standardize lab orders and imaging for things like fractures, burns, or skull fractures specifically. So once we developed this, after our initial round of design and troubleshooting, we were ready to go in April of 2019. And the 2 big questions were, is it feasible to implement a tool like this related to child maltreatment into the ED setting to work this into our pre-existing workflows? And second, if introduction of the tool would affect clinical management and reporting of suspected child maltreatment. So to evaluate this, we collected data into 2 periods, both pre-launch and post-launch. So during both periods, we collected data about children under 10 who came into the emergency department. We collected patient demographics, things that would have triggered the best practice alert and the firing rate of the best practice alerts, CPS reporting, and then clinical compliance with AAP recommendations for 4 specific metrics, which were less than 6 months with a bruise, less than 12 months old with a fracture or intracranial hemorrhage, or less than 24 months where anything was reported to CPS. Post-launch, we then also tracked the child abuse screen completion by nurses and the trigger rate, as well as the order sets. Here we can look at the screening rates for the child abuse screen. Initially after launch, this was relatively low at about 50 to 60%. We provided a few subsequent rounds of education, but I think most importantly moved the location of the screen, which was initially at the very bottom, all the way up to be more visually prioritized and fit in with more of the typical standardized screens. After doing that, we saw rates go from 50 to 60 to around 80 to 90, which is consistent with our other common nursing screens done here. We also saw the trigger rate go from being relatively high immediately after launch at about 7 to 8% to kind of evening out at about 1 to 2%. This was relatively consistent with what had happened at University of Pittsburgh as well. After providing additional education about some of the questions and clarity to the nurses, we got a more even level of response. Big things as far as outcomes was we tracked the compliance with the AAP recommendations in each of those metrics and didn't see any significant change in those. We did notably lose our only child abuse pediatrician midway into the live period. So although this didn't show a significant improvement, it at least showed stability, even in a case where we had now lost our most important expert suggesting that the CDS at least allows physicians to help provide high quality care and have a tool to consult. We did see that in about 50% of the cases of children who met a metric, the order sets that we designed were specifically used. We also did have providers complete a survey regarding their feelings about the tool and generally had people report satisfaction with using it. More significantly, we saw increasing rates of report to Child Protective Services after implementation, and this was significant. It was 0.6% of cases in the control period, 0.9% live period. Specifically, we also saw that there were much higher rates in cases with a positive child abuse screen versus those where it was negative or not completed. General conclusions were that it was feasible to implement a system like this. We were able to integrate it into our pre-existing workflow, both on the nursing and provider side. As far as management changes, we saw compliance with AAP recommendations despite the loss of our expert and did see increased reporting to CPS.
Hi, and thank you on behalf of my co-authors for the opportunity to present this work on the Boston Febrile Infant Protocol. I will start with the disclaimer that our algorithm uses days as an exact measure, but I will be speaking today about 1 to 2 month olds for ease. I will start with a brief background. We pay particular attention to fever in young, well-appearing infants because the risk of serious bacterial infection, or SBI, in this population approaches to 7 to 11%. Again, we are only talking about the non-ill-appearing infant without signs of a focal infection. We have classically attempted to identify a low-risk group of infants who are safe for discharge home using peripheral white count and differential as well as the absence of pyuria or CSF pleocytosis if tested. As with others, we began rethinking our approach to infants 1 to 2 months of age for several reasons. There's a changing epidemiology with decreased rates of bacteremia and meningitis for infants in their second month of life. There's mounting evidence that white count does not provide accurate identification of low-risk patients, and increasing evidence that procalcitonin is diagnostically superior than white count for identifying bacterial infections, especially invasive bacterial infections, or IBI. We implemented a revised febrile infant algorithm in 2018, paired with a quality improvement initiative to rapidly adopt the new algorithm. Importantly, 2 key changes were instituted simultaneously with the revision. 1, procalcitonin was added to normal UA and white count to redefine low-risk criteria. Specifically, CSF analysis was no longer part of the risk stratification. And 2, empiric antibiotics were no longer recommended for low-risk infants prior to discharge. These changes reflect our belief that the addition of procalcitonin would define a subset of the low-risk patients who could be managed safely as outpatients without routine LP or empiric antibiotics. We included well-appearing febrile infants aged 1 to 2 months without signs of focal bacterial infection. As expected, we removed patients with other risk factors. A QI initiative with a pre-post design was planned where the care of the target population was reviewed retrospectively for the 18 months pre-implementation and prospectively for the 24 months post-implementation of the revised pathway. The primary outcome measures were the reduction of LPs and antibiotic administration. Admission rates, ED revisits, and missed diagnosis of SBI and IBI were monitored as balancing measures. QI processes were used to disseminate this revised algorithm and reinforce uptake. If patients were considered high risk by biomarkers, we recommended LP, antibiotics, and consideration of the need for admission. For low-risk patients with procalcitonin less than 0.2 and normal white count, LP and antibiotics were not recommended, and the patient was eligible to be discharged home. After exclusions, there were 290 pre-implementation and 326 post-implementation patients for analysis. The pre- and post-implementation groups were similar in demographic and clinical characteristics. Procalcitonin was acquired in 89.8% of patients evaluated after implementation of the revised pathway. A P-chart was used to assess the impact of the intervention on the outcome and process measures in the post-implementation period. X-axis is time here, pre and post revision, and Y-axis is the percentage of patients receiving LP. The red arrow signals the addition of procalcitonin to the revised clinical pathway. With the revised algorithm, the proportion of infants who underwent LP decreased from a baseline of 66.2 to 31.9% for a 34.3% absolute reduction. As can be seen in the P-chart above, the revised pathway led to a sustained reduction in LP over the 24 months since pathway revision. This P-chart is for antibiotic administration. Again, the x-axis is time, pre and post revision, while the y-axis is percentage of patients receiving antibiotics. The red arrow again signals the addition of procalcitonin to the clinical pathway. Antibiotic administration decreased by 26.2% and has been sustained throughout the subsequent 24 months. Among discharged infants specifically, antibiotic administration decreased by 40.1%. Although you have already seen in the P-chart, here you see pre and post comparison of LP and antibiotic administration as well as the unanticipated decrease in admissions. There was no increase in the revisits or revisits requiring admission. And importantly, post-revision there have been no adverse outcomes related to missed SBI or IBI cases. To summarize briefly, we report the successful implementation of a revised clinical pathway for febrile infants 1 to 2 months of age, resulting in a safe and substantial reduction in LPs and antibiotic administration without increasing hospitalizations, ED revisits, or missed IBI. We believe the pace of uptake and acceptance of our pathway was influenced by the general desire to safely limit invasive, low-yield procedures when possible. We recognize this single-center study may not be generalizable to other centers and acknowledge we were not powered to detect adverse outcomes related to missed infections. We hope to perform future multi-center cohort studies to evaluate patient satisfaction and cost-effectiveness of this approach. Thank you so much for my co-authors, and thank you for your time.
Hi, my name is Michele Bresler, and I'm a current second-year pediatric resident at St. Christopher's Hospital for Children, located in Philadelphia, Pennsylvania. Our research project is entitled Effectiveness of a Screening Tool in Identifying Non-Accidental Trauma in Children Less than 2 years of age in a large urban pediatric level 1 trauma center. We have no disclosures. Child abuse is one of the leading causes of mortality in children. In many cases, up to 75% are missed by medical professionals due to failure to identify the signs of abuse. A study by Evelyn Lowers and colleagues in 2008 found that with the implementation of an intervention, the number of suspected child abuse cases detected was increased. This image is from the Pennsylvania Department of Human Services and shows the extent of child abuse in Philadelphia County, where our hospital is located. It also shows why we found this topic of such importance. As you can see, there were over 5,000 reports of abuse, with 800 substantiated in 2019. And 277 of those reports were for physical abuse. At our hospital, prior to November 2017, triage screening documented a yes or no to whether there was evidence of abuse. With the implementation of our 2-question screening tool, child abuse screening was now documented as a yes or no to 1, did the injury occur in a child under 5 years old, and 2, did the injury happen at home? A yes to both questions flagged the chart with a positive screen. This image further explains the triage screening protocol, but for sake of time, I'm going to skip over it. So our objective of the study was to determine if this St. Chris screening tool led to an increase in the number of non-accidental trauma being formally identified for evaluation in children less than 2 years old. We specifically narrowed our patient population to those under 2, since the greatest rates of abuse are in this age group, as well as these patients are often nonverbal and must be screened since they can't communicate their own stories. To gather our data, we completed a retrospective chart review looking at 2 years of suspected child abuse cases prior to the screener implementation and 2 years following the screener implementation. The data was then analyzed and compared using a chi-square analysis. We reviewed a total of 442 patients, 158 pre-screening, and 284 post-screening tool. Looking at these graphs, you can see that the gender distribution was relatively equal pre and post screener, and that majority of our patients were under 1 year of age for both groups. This chart depicts the month of patient presentation to the emergency department and shows a rise in the summertime months. We can speculate that this is due to a combination of kids spending more time at home versus in school and more injuries in general as kids are more active outdoors. A second spike appears around November, which could possibly be secondary to familial holiday stress, although it does drop dramatically in December. The chart below the graph depicts the time of day to presentation to the ED. It shows most arriving in the evening, which would be after school and after parents return from work. Our results show statistically significant difference, with more of the suspected child abuse cases having a positive NAT screen after implementation of the new screening tool. It increased from around 25% to 80% with a positive screen. These graphs break down the primary injuries recorded by the emergency department. The teal blue portion of each chart signifies a primary injury of physical abuse. You can see that only 32% pre-screener were identified as physical abuse, while post-screener 90% were. With the screening tool, the medical staff in the ED got better at specifically identifying abuse and utilizing the ICD-10 code for physical abuse. We did not see a statistically significant difference in the length of stay in the ED between the two groups. However, patients spent more time overall in the hospital before the screening tool. So even with a longer emergency department stay, the total hospital length of stay was shorter, which leads to decrease in hospital costs. By initiating more of the workup immediately in the ED, less had to be completed once the patient was admitted. You can see here that post-screener, there was a significant increase in the number of NAT protocols that were fully completed from 47% to 64%. This protocol consisted of filing a CY47, obtaining a skeletal survey, child abuse labs, and a CT head if the child was less than 1 year old. Here's a more complete image of the full NAT protocol that's utilized at St. Christopher's, but again, for time, I'm going to skip over this for now. To orient you to this slide, the bright blue region depicts official diagnoses of abuse, while the red depicts high concerns of abuse. There was no significant difference between the groups for either of these, but the number of patients with no child protection team consult and therefore no diagnosis given, as seen in the dark blue, was significantly decreased from 40% to 22%. This shows that with the implementation of the screening tool, the ED was better at evaluating patients properly as more were seen by the child protection team. More reports were also made to Child Protective Services after implementation of our tool. It increased from 69% to 97%. Almost every patient that was suspected of abuse had a proper report filed. Overall, with the implementation of a brief 2-question child abuse triage screener, we saw more positive screens concerning for abuse, so more patients were identified earlier on. We saw more evaluations by the child protection team, showing more thorough workups, and more reports were filed to Child Protective Services, although there was no significant difference in official diagnoses of abuse. Thank you so much for your attention. I really appreciate it. We welcome any questions or comments at this time. Thank you again.
Hello, everyone, and welcome to my talk entitled Physician Self-Identified Race in Opioid Prescription Practices in Upper Extremity Injuries in the Pediatric Emergency Department. I'm Dr. Joseph Langham. I am at Emory University and Children's Healthcare of Atlanta in Atlanta, Georgia. The other authors involved with this study are Dr. Sharita Holmes, Janet Figueroa, Dr. Shrikant Iyer, Dr. Sarah Lazarus, Scott Gillespie, and Dr. Carmen Sultan. Minority children receive fewer opioid analgesics when they present to pediatric emergency departments, and this is well documented in the literature. What we specifically wanted to do was to assess for racial concordance. So we were looking at both white and non-white physicians to see if they both prescribed fewer opioids to non-Hispanic Black children presenting to pediatric emergency departments with upper extremity fractures. We retrospectively examined our EMR and also sent out a physician survey. So our inclusion criteria included any child that was aged 2 to 15 years that presented to any of our 3 emergency departments in Atlanta with upper extremity long bone fractures. And we also sent out a red cap survey to physicians asking for their self-identified race and asking for their permission to have their patient charts included in the study and analyzed. So those physicians that did complete it and said yes, those were the patients who, along with the age requirements and the diagnosis requirements, met inclusion criteria. Our exclusion criteria was basically any patient who was admitted to the hospital or needed emergent operative management, or if they came back with a complaint that was associated with their initial presentation to the emergency department within 48 hours. Our primary outcome was to look at those patients who received an opioid prescription at discharge. What we did was we performed unadjusted bivariate analyses to assess for the association between the patient race and their receiving of an opioid prescription at discharge. We also further analyzed our data to look for the effect of provider race on the overall prescribing of opioids for patients. So we were looking at the racial concordance with that. We performed generalized linear models, and we also controlled for potential confounders in our adjusted models. And our results showed that had a total of 8,156 ED visits that met inclusion criteria. A total of 94 physicians completed the survey, 94 out of 128, which was about 60 or 70%. I forget the exact number off the top of my head. As you can see, there's not much of a significant difference between the races of the providers, 47% white, 53% self-identified as non-white. Patients tended to age around 5 to 10 years. Most were non-Hispanic white, most were male. Most either had commercial insurance or Medicaid, and most of the complaints that they were seen for were for radial fractures. Here we have bivariate analyses of the ED visits, and we looked at both those patients who received an opioid prescription at discharge and those who did not receive an opioid prescription at discharge. As you can see, which is outlined in red, just for the interest of time, we're kind of going over the most important part of the data that's highlighted the most. Non-Hispanic Black children received opioid prescriptions at far fewer rates than non-Hispanic white children. Non-Hispanic white children, of those patients who did receive an opioid prescription, 50% of them were non-Hispanic white versus 26.8% of non-Hispanic Black children. When we wanted to see if there was any difference between non-Hispanic Black patients and non-Hispanic white patients receiving opioids, we performed logistic regression models to look at the odds ratios. We did notice that overall, all patients that were non-Hispanic white tended to get opioids at higher rates than those who identified as non-Hispanic Black, Hispanic, or other. But once we adjusted for it, removing potential confounders, we did lose statistical significance with that. Secondly, in order to assess for the racial concordance, we looked at non-white providers and white providers, and then also performed it again to see what their rates of prescribing were in association to non-Hispanic Black patients versus non-Hispanic white patients, Hispanic versus non-Hispanic white, and other versus non-Hispanic white. And initially, both non-white and white providers both prescribed opioids to non-Hispanic Black patients at far fewer rates than non-Hispanic white patients. However, once we adjusted for potential confounders, we did lose statistical significance, although there did seem to be an effect modulation that was also seen there, but it was not statistically significant, as I previously mentioned. So in conclusion, overall in our center, non-Hispanic Black patients did receive fewer overall opioid prescriptions at discharge for upper extremity fractures. However, in adjusted models, the association between self-identified provider race and patient race did not appear to be statistically significant. Thank you all for tuning in and listening to my talk. I'm thankful for your time, and I look forward to you reading my manuscript once it's published in the near future. Thanks, and have a great day.
My name is Tom Hagerman. I'm an emergency medicine resident at Henry Ford Hospital. I did this work with Amy Houtro at the University of Pittsburgh. and I'm going to talk about the prevalence of adversities related to social determinants of health among children with multiple emergency department visits. We have no disclosures. The emergency department often acts as a safety net for patients and their families that may fall through the cracks of the medical care system. For children specifically, environmental factors play an incredibly important role in their development and well-being. The American Academy of Pediatrics recommends surveillance for risk factors related to social determinants of health during all patient encounters. And thus, we wonder if there's more we can do in the emergency department to help mitigate the effects of these adversities. The SBIRT model of screening, brief intervention, and referral to treatment has multiple applications in the emergency department into the domains of alcohol use and substance use, and potentially could be applied to addressing social determinants of health identified by routine screening in the emergency department. However, there is a paucity of literature documenting the rates of various social determinants of health in the emergency department among children, and therefore it may be difficult to determine which factors may be the highest yield for future SBIRT programs. Therefore, in this project, we had two aims. We first wanted to identify social demographic differences between children in relation to the number of emergency department visits in the last year, with the hypothesis that there were likely health factors related to multiple visits, but also socioeconomic differences between these groups. Secondly, in order to identify which social determinants of health are most prevalent among frequent utilizers of the ED, we wanted to compare rates of multiple adversities related to social determinants of health, including food insecurity, housing instability, adverse childhood experiences, and unmet needs between these groups of children. To do this, we used a sample of nearly 102,000 children ages 0 to 17 in the 2016 to 2018 waves of the National Survey of Children's Health, which is an annual survey from the CDC and Census Bureau that examines the health and well-being of children ages 0 to 17 in all 50 states. The child level data is weighted to be nationally representative of nearly 70 million children across the United States. Data was collected through online and mail-in surveys by parents or other adult respondents. In the question asking respondents specifically how many times the child visited a hospital emergency department in the last 12 months was used to separate the sample by frequency of ED visits. We first wanted to compare demographic differences related to the frequency of ED visits. Overall, about 19% of children ages 0 to 17 had one or more ED visits in the last year from 2016 to 2018, and 4.8% of children had 2 or more visits. Compared to children with no ED visits, children with more than 2 ED visits were generally younger and of Black or non-Hispanic race and ethnicity. Children with 2 or more ED visits were also more often in poor health, had special healthcare needs, and had a disability, some health differences that were expected. Children with 2 or more ED visits also more often had a single mother or lived in households other than having 2 biological, adoptive, or step parents. About 30% of children with 2 or more ED visits in the last year had a single mother, which was twice the rate of children with no ED visits. Children with 2 or more ED visits also more often experienced poverty compared to children with no visits. About 40% of children with 2 or more visits lived in a household less than 100% of the federal poverty level, compared to just 18% of children at the same poverty level with no ED visits in the last year. Children with 2 or more ED visits also more often had public insurance and more often had a gap in insurance coverage. However, there was not a significant difference in the rate of preventative health visits in the last year by frequency of ED visits. The vast majority, or about 95% of children in the sample, had a preventative health visit in the last year. Moving on to the rates of adversities related to social determinants of health. Overall, 6.1%, or the dashed red line, of all children experienced food insecurity. However, the rate of food insecurity for children with 2 or more ED visits of 13% was more than double that of children with no ED visits in the last year. Children with 2 or more ED visits were also more likely to experience high residential mobility, indicative of housing instability, which was an age-adjusted number of moves in the child's lifetime. about 11.6% of children experienced high residential mobility, and the rate of high residential mobility was twice that in the 2 or more ED visits group compared to children with no visits. Children with 2 or more visits also had a higher rate of multiple adverse childhood experiences, such as living with someone with a drug or alcohol problem, living with someone with severe mental health problem, or witnessing violence between adults in the home. Children with multiple ED visits also more often lived in unsafe communities compared to children without any visits. We also wanted to identify the rates of unmet needs in relation to the frequency of ED visits. Unmet needs in general were uncommon among all children. However, the 7.7% prevalence of unmet needs among children with 2 or more ED visits was much higher than the 2.2% prevalence of unmet needs among children with no visits. And specifically, the rate of unmet medical needs were different by ED visit frequency. In conclusion, we found disparate rates of adversities related to social determinants of health based on the frequency of emergency department visits, and identified multiple social determinants of health that may be amenable to screening in the emergency department. We also found that more than 65% of children with 2 or more ED visits in the last year lived in households at less than 200% of the federal poverty level, which in 2018 for a 4-person family was about $50,000. The prevalence of food insecurity, high residential mobility, adverse childhood experiences, and living in an unsafe community all increased in a stepwise fashion in relation to the number of emergency department visits. In the ED, using the SBIRT model of screening, brief intervention, and referral to treatment in connection to follow-up care may be a particularly useful way to initiate the process of addressing these adversities. Included references, and thank you for your time.
My name is Dr. Ted Heyming, and I'm here to present Criticality Index conducted in Pediatric Emergency Department Triage. The objective of our study was to develop and analyze the performance of a machine learning model capable of predicting the disposition of patients presenting to a pediatric emergency department based on triage assessment and historical information mined from the EHR. We included all ED encounters from March 2013 through December 2020 for those patients under 21 years of age. We excluded patients transferred to outside hospitals, those admitted to inpatient psychiatric units, or those that left without treatment or were AMA. This slide portrays the various categories of variables which included demographics, triage vital signs, triage assessment, healthcare utilization, and historical medications or diagnoses. 49 variables were considered during model development. Historical data was constrained to 6 months preceding the index visit. If a patient had not been seen before and had no data in the system, historical variables were coded as missing rather than 0. This slide shows our outcome classification. Patients were defined as high criticality if they were admitted or transferred to the pediatric ICU within 4 hours of admission. Patients who died within 4 hours of admission or who died in the emergency department. They were defined as moderate criticality if they were admitted to the general floor, and defined as low criticality if they were discharged home from the emergency department. With regards to model development, we split the data into a training set, validation set, and test set. This represents 50%, 10%, and 40% of the total data set respectively. We utilize XGBoost. This models complex nonlinear systems with automated management of missing data. The base model was used to exclude variables that contributed least to the accurate prediction of criticality. The threshold for removal was set at a 0.001 relative gain. Hyperparameter tuning was performed, and the validation set was then used to determine the optimal number of trees in the final model. This slide depicts the distribution of criticality for our data set. There was just over 584,000 visits. 60.3% were made by patients who visited the ED more than once. This slide depicts the demographics of our data set in 3 concentric rings. The inner ring is gender. Females accounted for 46.5% of all visits. The middle ring is ethnicity, and the outer ring is age. The median patient age was 4 years. The 1 versus all area under the receiver operating characteristic curve for high and moderate criticality was 0.982 and 0.968 respectively. This is depicted in graph A and B. At 90% specificity, the sensitivity for high criticality was 0.97, and 0.922 for moderate criticality.
This graph depicts the variables by feature importance in order of decreasing importance based on relative gain. Several of the top 10 variables will be discussed in more detail. The interpretation of features is more complicated in an XGBoost machine learning model than to regression models. SHAP values were calculated to elucidate how individual variables contributed to criticality, i.e., whether an individual variable nudged a patient towards high or moderate criticality. While useful, these are greatly simplified representations of complex model behavior and do not capture the modifying effect of one variable on another.
The following 3 slides depict the SHAP values for 9 of the top 10 most important features in our model. On this slide, the y-axis of each graph depicts criticality, and the x-axis depicts a binary yes-no term, yes indicating the variable was present. The most important feature of this model, as determined by gain, was history of IV medication administration, the leftmost graph. SHAP analysis of history of IV medication suggested that a history of receiving IV medication within the past 6 months was associated with both high and moderate criticality. Several healthcare utilization variables, including history of hospitalizations, were among the most important features. A history of 1 or 2+ hospitalizations within the past 6 months, the middle and right graph, tended to push the model towards high or moderate criticality. The 3 of these demonstrate how our machine learning model uses historical data that clinicians may not have time to locate and evaluate. This highlights the importance of using historical data in creating a predictive model for hospital admission. This slide depicts variables reflecting triage assessment, such as capillary refill, ESI level, and the use of a supplemental oxygen device, all of which were features of high importance. Though there were few patients included in the study with a cap refill greater than 5 seconds, the leftmost graph, this measure, not surprisingly, was more predictive of high criticality. ESI levels of 4 or 5, middle graph, drove the model towards lower criticality, likely reflecting accurate ESI designation at the time of triage. The rightmost graph shows the model tended toward high criticality in the setting of a patient who presented to triage using a supplemental oxygen device.
Age, as shown in the left graph, was an important feature. The youngest patients were predictably more likely to be high criticality. However, after a decrease in criticality at approximately 2 years of age, risk of high criticality rose in a linear fashion. Another healthcare utilization variable, history of 1 ICU admission, middle graph, was correlated more strongly with high criticality than with moderate criticality, suggesting that patients who were previously admitted to the ICU tended to be admitted to the ICU again. Interestingly, no vital signs were found among the top 9 most important features. Heart rate was number 10. As you can see in the rightmost graph, it demonstrated a parabolic curve with a trend towards high criticality at the lower and upper ranges of heart rate.
In conclusion, the predictive accuracy of this model suggests that the integration of such a model into clinical practice offers opportunities for improvement of our clinical decision making. Thank you for coming to my presentation.
Thank you for attending this very brief talk on COVID-19 anxiety and burnout in pediatric emergency department healthcare providers. So unfortunately, healthcare providers in the ED are at increased risk for experiencing high levels of burnout, which can have a negative effect on patient safety and care and provider mental health and well-being. And in turn, provider stress and anxiety can also further influence burnout. So then the COVID-19 pandemic comes along, and as I'm sure you're all aware, the pandemic has introduced a myriad of challenges, including heightened stress, anxiety, and personal and family safety concerns, along with changes in patient care, procedures, and workflow. And previous work has shown that ED providers report increased stress during past pandemics and the COVID pandemic. There's been limited data in pediatric EDs, but one survey of pediatric ED providers did show that despite low census, healthcare providers and staff were experiencing heightened anxiety during the pandemic. So the aims of the study were to look at burnout in healthcare providers in a pediatric ED during the COVID pandemic, and then explore relations among COVID anxiety and burnout, and lastly, look at whether confidence in providing COVID-related care and confidence in employer-insured personal and family safety influence burnout. Our sample included 132 healthcare providers in a pediatric ED, about half of which were nurses. They completed demographics measures and rated their level of anxiety about the COVID pandemic between 0 being not anxious and 100 being very anxious. They completed a willingness to work survey, which is designed to assess willingness to work during health emergencies. And the items assessed confidence in COVID-19 related care and confidence in employers ensuring their personal and family safety. They completed the Maslow Burnout Inventory, which yields 3 subscales of burnout: emotional exhaustion, personalization, and personal accomplishment. And for personal accomplishment, lower levels represent higher burnout. And they completed surveys in April and May of last year. So looking at the first aim and the prevalence of burnout, we saw that about 25 to 26% reported moderate to high emotional exhaustion burnout, about 39% reported moderate to high depersonalization burnout, and about 41% reported moderate to high levels of personal accomplishment burnout. We did see that nurses and technicians reported higher personal accomplishment burnout, so that means lower reported personal accomplishment than physicians did, and we didn't see any other differences in terms of demographics or job factors. And looking at our second aim and the Anxiety Burnout Association, we did see an effect for sex here where females reported higher COVID-19 anxiety. And looking at the correlational analyses, we saw that COVID anxiety was significantly associated with all burnout scales and expected directions. And the regression analyses indicated similar results. So controlling for sex, COVID anxiety significantly accounted for about 7 to 20% of the variance in burnout scales. And now lastly, looking at confidence in COVID-related care and confidence in employers' ability to ensure personal and family safety and whether that imposes burnout. For these figures, the red bars indicate a lack of confidence. And across almost all items in all burnout subscales, those who reported that they did not have confidence in the ability to provide COVID-related care or their employer's ability to ensure their personal or family safety, for the most part, endorsed higher levels of burnout. So pulling this all together, we saw 26 to 41% of pediatric ED healthcare providers reported moderate to high levels of burnout during the COVID-19 pandemic. And these represent substantial rates. However, they are lower than what's been seen in adult ED healthcare providers. However, COVID-related anxiety was associated with higher burnout, and results suggest that a lack of confidence in ability to safely provide COVID-related care and employers' ability to ensure personal and family safety may have an effect on burnout. Limitations are important to note. So this is a cross-sectional study. We canned for causation, and we did not assess pre-COVID burnout levels, so we don't know how this compares to the healthcare providers' pre-pandemic burnout levels. And clinical implications, so results suggest that assessing COVID anxiety and confidence in COVID-19 safety may help identify healthcare providers at increased risk for burnout, and also the need for further training and support, so possibly increasing access to COVID-19 care education and resources directed towards ensuring healthcare provider personal as well as family safety may help alleviate burnout in pediatric ED healthcare providers. So thank you so much. I welcome your questions.
Hi, good morning. My name is Tian Liang, and I am a pediatric emergency medicine physician at New York City Health and Hospitals, Kings County in Brooklyn, New York. I'd like to thank the Society of Academic Emergency Medicine for allowing me to present my research today on the utilization of pediatric emergency care in New York City during the coronavirus disease 2019 pandemic. The authors have nothing to disclose. New York City was an early epicenter of COVID-19 infections and also home to the largest public healthcare system in the United States, named New York City Health and Hospitals. The system serves over 1 million New Yorkers across all 5 boroughs. During the height of the pandemic, stay-at-home orders, social distancing, school and business closures, and mask mandates were instituted by the state and local government. These safety measures significantly altered the landscape of healthcare utilization in the city. As providers working within the system, we noticed a shift in pediatric emergency utilization during this time, and we sought to evaluate the characteristics of pediatric ED visits in New York City public hospitals during the COVID-19 pandemic compared to 2019. We conducted a retrospective cross-sectional analysis of patient visits aged 21 years and under to 9 New York City public hospital EDs. Patient visits to psychiatric EDs and labor and delivery were excluded from our analysis. We collected patient volumes, demographics, visit types, ESI levels, and dispositions from January 2020 through November 2020, which included the months preceding and after the height of the COVID-19 pandemic. We then compared this data to the same time period the year prior in 2019. There were a total of 94,724 pediatric ED visits from January 2020 through November 2020, which represented a 44% decrease in volume compared to the almost 170,000 PED visits from the same time period in 2019. About half our patients were male in both years, and the median age of patients were about 8 years old. Our patient demographic comprised mostly of Black and Hispanic patients, followed by Asian and then white patients, and these percentages stayed consistent between 2019 and 2020. The mode of arrival of our patients stayed consistent between 2019 and 2020. Most patients arrived through the waiting room, and less than 20% came via EMS. ESI levels between the 2 years remained similar, with most patients being levels 3 or 4. Though statistically significant, likely due to the size of our population, we did not find any clinically important differences in patient age, gender, mode of arrival, or ESI level between 2019 and 2020 in our New York City public hospitals. This graph highlights the total pediatric ED volumes across our 9-hospital cohort in both 2019 and 2020. 2019 is shown in orange and 2020 in blue in this graph. The pediatric ED volume in early 2020 was slightly increased compared to the same period of 2019. We then see the largest monthly decrease in volume for this year between March and April. There was an 84% decrease in volume during this time period, with 11,000 visits versus 1,900 visits respectively. This time period coincided with the first COVID-19 infection in New York City and the initiation of lockdown orders. Pediatric ED volumes then steadily increased throughout the summer, starting with Phase 1, which included construction, manufacturing, and some retail, Phase 2 with outdoor dining, hair salons, and offices, Phase 3 with indoor dining, and Phase 4 reopening with outdoor activities and gyms. Though pediatric ED volumes increased throughout the summer of 2020, they peaked at less than 50% of 2019 volumes. This chart highlights the weekly admission rates in our hospital system in both 2019 and 2020. From a baseline of about 3 to 5%, we saw an increase in admission rates in 2020, especially during the height of the pandemic, when admission rates increased to 9% in some weeks. Even as volumes increased throughout the summer, admission rates stayed elevated in 2020 compared to 2019. In conclusion, the COVID-19 pandemic and subsequent lockdown orders coincided with a sharp decrease in pediatric emergency utilization in New York City public hospitals. This volume decrease was sustained despite city reopening measures and continued throughout the rest of the year. In addition, a higher proportion of pediatric patients seeking emergency care during this pandemic were hospitalized. Our study had several limitations. We only compared pediatric ED utilization during the COVID-19 pandemic to one previous year. There are 11 hospitals in the New York City Health and Hospital System, but only 9 hospitals had adequate data and were included in the study. The 2 hospitals not included were community pediatric emergency ED sites. Some hospitals within our system were transitioning to a new electronic medical record between 2019 and 2020, which was the primary source for this limitation. Though we found a decrease in volumes and an increase in admission rate during the height of the pandemic, the reasoning behind this change is likely multifactorial, including parental fear of going to the hospital, social distancing decreasing the spread of infections, less playground trauma from school closures, and other reasons beyond the scope of this abstract. Thank you very much for taking the time to listen to our presentation.
Good morning, and thank you for listening. My name is Abba Atali, and I'm a third-year pediatrics resident at Nationwide Children's Hospital. Today I'll be presenting the results of our study entitled Application of the Pediatric Emergency Care Applied Research Network, PECARN, Febrile Infant Decision Rule to an expanded cohort of infants ages 0 to 28 days. Fever in young infants is a common cause for presentation to the emergency department, and the cause of fever ranges from environmental factors, viral illnesses, to serious bacterial infections or SBIs. While the majority of the fevers are not due to bacterial infections, a misdiagnosis of SBI carries a high risk of morbidity and mortality. Historically, infants aged 0 to 28 days are at highest risk for SBI. Resultantly, when they present to the ED with a fever, they typically receive a full sepsis rule-out including blood, urine, and cerebrospinal fluid cultures, labs, antibiotics, and admission. Given that only 8 to 13% of infants with fever will have an SBI, numerous groups have created clinical decision rules, or CDRs, to help risk stratify and identify infants who may be at lower risk for SBI and not require a full sepsis rule-out. Looking at the CDRs that have been created for febrile infants specifically, we start with the Rochester criteria in the 1980s, followed by the Boston, Philadelphia, and Milwaukee criteria in the 1990s, Step by Step in 2014, and finally PCARN in 2019. Looking more closely at the PCARN CDR, this is a clinical decision rule that aims to identify febrile infants at lower risk for SBI, namely urinary tract infection or UTI, meningitis, bacteremia, using 3 main lab criteria. 1. Absolute neutrophil count or ANC, 2. Procalcitonin, and 3. urinalysis. However, clinical decision rules are often applied to populations in which they are not validated. For instance, at our institution, septic rule-outs are initiated for reasons other than fevers. Based on this, our question of interest was, how does the PCARN febrile infant CDR perform in an expanded population? Our population of interest was as follows. We have all patients, who I'll define in a second, categorized into 3 groups. 1. Fever, defined as temperature greater than 100.4 degrees Fahrenheit measured in the emergency department or prior to arrival. 2. Hypothermia, defined as temperature less than 95 degrees Fahrenheit measured in the emergency department or prior to arrival. Or 3. Other clinical concerns, namely any presenting symptom prompting rule-out sepsis that was not fever or hypothermia. To evaluate our primary question, we conducted a retrospective descriptive chart review to determine the test characteristics of the PCARN febrile infant CDR in the following groups: fever, hypothermia, other clinical concern or OCC, and all patients. We included all infants aged 28 days or less who were evaluated in the Nationwide Children's Emergency Department from March 2017 to June 2019 who received a septic rule-out including blood, urine, and CSF cultures. We excluded patients who were born premature, had pre-existing conditions, had a prior NICU stay, or were missing data for the decision tool. We included 347 patients. 59.7% of all patients were male, 64% of all patients self-identified as white, and 58.2% of all patients had a public primary payer. Interestingly, we saw that most patients who received a rule-out sepsis for fever were older, and those who received a rule-out sepsis for hypothermia or OCC were younger. We wanted to see how the incidence of SBI varied on group, which is displayed in Table 2. We had 24 total SBIs. In all patients, the SBI incidence rate was 6.9%, and in those presenting with fever, it was 7.6%. UTI was the most common infection seen, and we had no cases of bacterial meningitis. Since young infants are at unique risk for invasive HSV infection, with high morbidity and mortality, we also noted the incidence of HSV viremia and encephalitis, of which we had 2 infants. 20 of 24 cases of SBI were in babies who presented with fever, and we had 4 cases of SBI in patients who presented in the OCC group. None of the patients with hypothermia had an SBI. Both of our cases of HSV infection presented with fever. We then looked to see how the babies would have been categorized by the PCARN febrile infant CDR based on their presenting symptom. We see that 42.9% of the overall cohort were still considered higher risk per PCARN. We then wanted to see how the PCARN tool performed in our overall population and with specific groups. The original PCARN values are seen in green. Of note, since we did not have any SBIs in the hypothermia group, we were unable to calculate any of these values. We see that in our cohort of all patients, the tool did not perform as well as it did in the original study. Performance of the CDR was poor, especially when we applied it to the population who received rule-out sepsis for OCC. Of all our groups, the rule performed best in infants who received rule-out sepsis for fever. Overall, the aim of our study was to see how the PCARN decision rule would perform in an expanded population. We saw that the CDR performs less well in this expanded population of infants aged 0 to 28 days, and especially poorly in those without fever. The CDR should not be applied to infants without fever for whom the tool was not derived. Of note, 20.1% of our cohort had no fever. Most infants with SBI had fever, though 4 or 16.7% did not have fever or hypothermia. Young infants with fever or other clinically concerning symptoms should still receive full sepsis evaluation to rule out an SBI. Certainly no study is without its limitations. Ours is a single-center retrospective study with a relatively small patient population. These are some of our references. Thank you so much.
Hello everyone, my name is Dr. James Ford and I'm giving this presentation on behalf of myself and my colleagues here at UC Davis Health. Today I'd like to talk to you about the utility of asymptomatic COVID-19 screening in adults in the emergency department. We, the authors, have nothing to disclose. High rates of asymptomatic infections with COVID-19 have been reported, with one study demonstrating that as many as 56% of patients with COVID-19 were in fact asymptomatic. Asymptomatic transmission is known to be responsible for a high percentage of new infections, with one study demonstrating that as many as 44% of patients became infected after exposure to an asymptomatic but known to be positive individual. A previous study from our group demonstrated that asymptomatic testing was of low yield when conducting testing in a low prevalence region. In this study, we aim to describe the use of an asymptomatic COVID-19 testing protocol in adult patients in the emergency department. We conducted a retrospective cohort study at a single tertiary academic emergency department in Northern California. We screened adults over the age of 18 who were tested for COVID-19 under the asymptomatic protocol between the months of May and October 2021. The COVID-19 test we used was a reverse polymerase chain reaction of SARS-CoV-2 RNA using nasopharyngeal swabbing. The primary outcome was positive COVID-19 testing, and patients that had positive tests underwent further data abstraction. County level data was used to estimate daily COVID-19 cases per 100,000 individuals in the region, and we present our data as simple descriptive statistics. A total of 7,408 patients were screened during the study period, with a mean age of 54 years and a standard deviation of 19 years. 78 total patients were found to be COVID-19 positive, representing about 1.1% of the study cohort. However, upon further assessment, 32 of these patients were actually found to have signs or symptoms of COVID-19. 48 patients underwent infectious disease consultation, and 13 patients were treated for COVID-19 with things such as oxygen, remdesivir, and dexamethasone. Here is a graph demonstrating or comparing the local rate, the Sacramento COVID-19 case rate per 100,000 to our local institutional asymptomatic COVID-19 rate in our adult patients. We see that the local community rate ranged from 4 to 25.74 cases per 100,000 during the study period, and no positives were found that were asymptomatic when the rate was less than 4 cases per 100,000. So in summary, COVID-19 testing is of low yield and the daily community rate is less than 4 cases per 100,000 individuals, and about 40%, about half of our COVID-19 positives had signs or symptoms attributed to COVID-19, suggesting that the actual rate of asymptomatic infection was lower than the 1.1% we report. So in summary, ED physicians should assess for COVID-19 signs and symptoms even when patients present for other indications other than shortness of breath or things that could be plausibly related to COVID-19. Here's a list of my references. Thank you for your time today.